You guys all back with me? Kind of, sort of. There we go. All right. So when we're talking about differences between venous and arterial ulcerations, there's some telltale differences in the characteristics in their appearance, as well as the location or the typical locations of these ulcers. For venous ulcers, they're typically near, just above the medial malleolus, so that inside ankle, around that inside ankle. That area is known as the gator zone. Whereas with arterial ulcers, we could typically see them around bony prominences, the tibial areas. So we see them around the shin, on the ankle themselves. We could see them on the dorsum of the foot, the toes especially. There's differences too in terms of pain. Typically arterial ulcers are very painful, whereas the venous ulcers are not. Arterial ulcers are typically very deep and have regular borders to them. Venous ulcers tend to be a lot more shallow and have more of an irregular pattern to it. There's very little bleeding associated with arterial ulcers, whereas venous ulcers tend to ooze a little bit. Again, patients with venous ulcers have that brawny discoloration, so that brown pigmentation of the skin. There's often presence of varicosities. And then if we remember back to arterial, some of the things we see with the patient that has arterial disease, loss of hair, shiny, scaly skin, thickened toenails. From my own personal experience, venous ulcers smell horrible. It's terrible. I mean, arterial ulcers don't smell good, but venous ulcers is just, oy. So God bless anyone who gets a job working in wound care. It's tough. So when we're talking about varicose veins, they can be broken down into two subsets, primary varicose veins and secondary varicose veins. So primary varicose veins, the way I kind of think about it is it's just reflux that in the superficial veins that just happens, as a, maybe due to hereditary issues. There's no underlying predisposing condition like a DVT or something along those lines to cause the veins to become incompetent. It's just something that happens. Maybe the patient's aging. They have hereditary issues that they develop these incompetent veins. And these are, the varicose veins are the primary cause or the primary condition. Secondary varicose veins, I think of it as varicose veins caused by something else, influencing it and causing that reflux in the veins themselves. So some of the things that could cause secondary varicose veins would be a patient who has a DVT that damages the valves within the deep veins, and then you wind up with reflux in the deep veins that then propagates and causes reflux into the perforators as well. So you have increased venous pressure within the deep system, that pressure gets translated to the perforators. You wind up with incompetent perforators and then blood flow refluxing back into the superficial veins. So again, primary varicose veins, history of DVT is usually rare. Sometimes you can feel the presence of a palpable cord. So this is, again, just another schematic showing normal blood flow, that should typically occur within the venous system. So we're looking at the lower extremity. So we have this is the larger deep vein headed back up towards the heart, greater saphenous or superficial vein headed back up, and then the perforator veins. So typical blood flow again should be from superficial into the deep system across those perforators. This is an example of if we have an incompetent greater saphenous, so blood flow coming back down the greater saphenous. But there's a chance that some of that blood flow can be shunted back over into the deep system through those perforators if the perforators are still competent and do not exhibit reflux. So that could, reduce the severity and prevalence of the patient developing varicose veins. The last one, C, is a diagram showing if the patient has reflux within that deep system, oftentimes that pressure then gets translated to the perforators, and the perforators wind up becoming incompetent as well. So we have dilatation of the deep veins, which adds to increasing severity of those of the reflux. That extra blood will also dilate the perforators and will lead to increasing reflux within the perforators, and that blood flow then gets translated back into the superficial system and eventually leads to reflux in the superficial system, and you wind up with the varicose veins as a result. If we remember back to our calf muscle pump mechanism, so this is just a diagram showing our calf muscle pump. We know that the venous system relies on the calf muscle pump in order to circulate the blood within the venous system. We don't have that pumping mechanism of the heart at this point to circulate the blood, so we rely on our respiration and our skeletal muscle contractions. So this is just showing an example when the muscle contracts, it forces close those distal valves and opens up the proximal valves to allow blood flow to propagate towards the head. So this is just a little more detailed diagram showing the directions of blood flow involved in rest, contraction, and relaxation with the calf muscle pump. When the calf muscle is at rest, normally we should have blood flow returning back up towards the heart, traveling upwards in both the deep and the superficial veins. And we should have normal blood flow across the perforators from superficial into deep. During contraction of that calf muscle, we get blood flow again turning back up towards the head, and we get closure of that distal valves, opening of the proximal valves, allowing blood flow to return up. And then during relaxation of that calf muscle, we get movement of blood across the perforators. So when we're doing a physical exam on a patient that has varicose veins, one of the most common valves to become incompetent is that saphenofemoral valve. So we can actually see this pretty common when we're doing our ultrasounds here in the lab. That's when we're up at that junction of the GSV with the common femoral. So there's a valve right at that junction of that vessel, and that's typically one of the first ones to become incompetent. And when that becomes incompetent, it can start leaking, or the blood flow starts leaking back and starts traveling down the superficial system and increasing the venous pressure within the superficial system. So we may not, the patient may not present with varicose veins at that level of that incompetent valve, and only present with more distal varicose veins. But that's where our venous insufficiency, our reflux tests become quite critical. We're going to learn in a little bit. In order to, cure this patient's insufficiency and treat their varicose veins, we have to understand and be able to image which vessels are involved, which valves are incompetent, the level of the incompetence, and which tributaries are involved as well. Locate the perforators that could potentially be incompetent, and then treat and ligate or remove those valves of those vessels which are incompetent. So you can appreciate that these varicose veins can get quite dilated, quite large. Oftentimes they can be quite painful as well. If you can imagine, all this pressure within these vessels themselves, they can be, quite unsightly too.
Yeah, that is scary.
Yeah. And then you worry about these varicose veins also becoming thrombosed as well. So if you imagine all this blood just collecting and pooling within these large varicose veins, they can oftentimes become thrombosed. If you remember back, we have a connection between the greater saphenous and that small saphenous through that vein of Giacchini. So sometimes it's referred to as a proximal extension of the small saphenous. So it's important to be familiar and know your tributaries of the superficial system, know the location of your perforators, being able to image perforators. So that's why a true detailed venous reflux study can be very time consuming and very detailed. So if you're working for a vascular surgeon who specializes in doing reflux studies and venous ablations, these studies can take quite a bit of time to really map out where exactly the reflux is occurring and which tributaries are involved. It involves also measuring, diameter of vessels, as well as severity of the reflux at the different areas. So this is just another chart kind of breaking down chronic arterial insufficiency versus chronic venous insufficiency. So remember, insufficiency is inadequate blood flow. So pulses, again, with arterial would decreased or absent. Again, some of the skin color changes are different. Arterial issues, typically the patient to be cool to the touch. With venous insufficiency, the skin will have normal temperature. Arterial, we can have a patient with pallor or dependent rhubarb. Venous insufficiency typically will have normal skin color, except for the areas where we have that hyperpigmentation. This is just another chart showing some of the differences between arterial and venous, and also included in this chart is a patient, who is diabetic. So just remember, when you get down to here on ABI and pulses, they may not be reliable on a patient with diabetic. Why? Because they could potentially have that medial calcinosis. So those calcified arteries won't allow us to obtain that ankle-brachial index. Venous, the patients will have edema. Arterial, that edema could just be localized. The wound, again, will not have regular borders. It'd be exuding or granulating. Arterial ulcers are typically dry, whereas venous ulcers typically ooze. Venous ulcers can also become quite large as well. So when we talk about venous treatments and therapeutic interventions, we're going to talk first for treatment of deep vein thrombosis. So we can administer medications prophylactically, meaning as a preventative measure. So if we know a patient, has a history of DVT or they're high risk for developing DVT, say they have, like factor V Leiden, for instance, that hereditary clotting disorder. These patients would typically be on some sort of prophylactic anticoagulation or medication to prevent deep vein thrombosis from forming in the first place. There are medications that are administered for medical treatment of DVT. There are some surgical interventions for the treatment of acute DVT. So prophylactic treatment, we're trying to reverse Virchow's triad. So it may not necessarily even be something like medication. We could try and reverse trauma to the vessel walls. So try not to actually stick the vessels, reduce the number of times we have to draw bloods. So that's why oftentimes they like to put in a central line, especially patients that are a hard stick, as opposed to repeatedly having to stick the patient, to get bloods and labs. They'll try and put in a PICC line to make it a lot less traumatic to those vessel walls. Decrease stasis. So have the patients get up, move around, put on what are called pneumatic cuffs. So oftentimes you'll see in the hospital patients, particularly in the ICUs, they have these cuffs around the ankles that will inflate and deflate periodically and that's to stimulate or simulate a muscle contraction to activate that calf muscle pump. Potentially giving the patient something like compression stockings. And then, of course, there's medications that can be given prophylactically, things like heparin, aspirin, Coumadin, Lovenox. So when we talk about medical treatment for deep vein thrombosis, there's an important distinction you have to make between anticoagulation medications versus thrombolytic medications. So when we talk about these medications that we give to patients with DVT, you often hear it referred to as, oh, they put me on blood thinners. So those are these anticoagulation medications, those blood thinners. The important thing to remember is that these blood thinners don't actually dissolve DVT. They don't actually get rid of blood clots. They only prevent new blood clots from forming. So that's typically a registry question or a test question, about the difference between thrombolytic or thrombolysis medication. So lysis is the actual breaking down of something versus anticoagulation medications. So again, these medications prevent the propagation or the development of new thrombus from forming. They don't actually lysis. They don't actually break down the clots. Some of these common medications that you're going to hear in the hospital is going to be heparin. That's the big one. Typically, it's given intravenously for 5 to 7 days. And then these patients are then put on oral Coumadin or warfarin is the drug name. And that's for a period 3 to 6 months following. There's some other anticoagulation medications that are on the market as well that you may encounter, things like Lovenox, Xarelto, Pradaxa. Some of these things may require therapeutic anticoagulation for femoral popliteal vein thrombosis. And remember, there's something called an IVC filter that we're going to learn about in a little bit. And this can act as an alternative for patients for which anticoagulation is contraindicated. So if you have a patient who has a gastrointestinal bleed, perhaps a stroke, they have a hemorrhagic stroke in their brain, and we're not able to give these anticoagulation medications, they're contraindicated, those patients would typically wind up getting an IVC filter placed in order to prevent pulmonary embolism. So the other medication is going to be thrombolytic agents. So now these are medications that actually do lysis or break up deep vein thrombosis. So they're not commonly used in patients with thrombus embolism or DVT due to a substantial proportion of patients with contraindications to thrombolysis. It's more commonly used in patients with extensive iliofemoral venous thrombosis, where the risk of developing post-thrombotic syndrome is high. So these thrombolytic enzymes, they break down the thrombi into soluble products. So these are the names of some of these thrombolytic agents like TPA or streptokinase. These medications are given intravenously, and they do run a risk of the patient developing hemorrhage. So basically what this process is, they'll go in with a catheter, into the area that's thrombosed. So typically this thrombolysis is reserved for situations where the patient has very, very extensive DVT, and they're worried that this DVT could potentially become limb threatening to that patient. So very large, like common iliac, IVC, DVT, that's not resolving. The patient's exhibiting symptoms of developing cyanosis within the extremities. They actually go into the vessel itself with the catheter, and that catheter delivers that thrombolytic medication directly into the vessel itself to try and break down that clot itself. I've seen this used in patients who've had portal vein thrombosis and attempt to try and reopen the portal vein. Renal vein thrombosis and attempt to, in order to try and save the organ, to open up the renal veins to promote flow again. So just so this is just showing a thrombocatheter, thrombectomy catheter. So we talked a little bit about this last year. With clots or DVTs, they're very soft, so they're actually able to insert the catheter into the vessel, push the catheter through the clot itself, and then extend this device that opens up and actually extract. There you go. So this device extends up through the clot itself. Will then open up, and then you can actually pull forward the thrombus. So then we're talking about surgical treatment for DVT. So these are used, indicated only if medical treatment is failed or is contraindicated. So we can have something called vena cava interruption. An interruption device may be placed in the IVC just below the renal veins. So this is what's called or considered an IVC filter, or inferior vena cava filter. So the reason we put it just below the level of the renal veins is because we don't want thrombus to enter into those renal veins. We want to try and protect the kidneys. So typically these IVC filters sit just below the level of the renal veins. Some of the common names that you'll hear is Greenfield filter, or umbrella filter, or the Venatech filter. We can also do, again, thrombolectomy or thrombectomy. So that's the actual surgical removal of the thrombus within the vessels themselves. So it can be done with a rotating device, a mechanical device, motor driven, which has a rotating action that breaks up the thrombus and then through suction removes it out. Or we can do a phlebectomy. So this is a vein that's extracted with a phlebotomy hook to actually remove the vessel itself. This is just a picture showing some various types of IVC filters that are in production and in use. So you can actually visualize these on ultrasound in a patient's IVC when imaging and getting pictures for the IVC. So you go, here's an ultrasound image, patient's IVC, and you can see the IVC filter placed here in the psychogenic structure. So there are temporary filters that can be placed. This is just another hydromatic thrombectomy hook. So you can enter into the vessel and try and extract the thrombus itself. Some other treatments. So when we're talking about our superficial veins, so patients with superficial venous thrombosis or phlebitis, we can have ablation or heat application. So potential treatments, they could be compression therapy. We can use non-steroidal anti-inflammatory drugs to treat venous insufficiency. Patients can potentially have compression therapy to counteract that venous hypertension. We can treat them with surgically removing the disease segments. These patients that have chronic venous insufficiency and wounds, they can have hyperbaric oxygen treatments to help try and heal those ulcers. Some other treatments that are available. So in patients that have axillary subclavian thrombosis, if it's caused due to a catheter being placed, so for instance, a patient who has a central line or a PICC line, we administer anticoagulation, so IV heparin, and then we remove that catheter because that catheter is acting as that catalyst or that surface for clots to form on. So we're going to remove the catheter that the clots are on, and then administer anticoagulation. If there's no underlying cause for axillary subclavian vein thrombosis, we have to consider things like clotting disorders like thrombophilia. The patient will have a genetic workup. Maybe they have heparin-induced thrombocytopenia, perhaps factor V Leiden, one of the inherited clotting disorders. Or it could potentially be caused again by that intrinsic compression of the axillary and subclavian veins. And that could be due to our thoracic outlet syndrome. So treatment for thoracic outlet syndrome could involve removal of that first rib and associated muscles. So that's a very involved procedure that takes a long recovery if it is an issue with thoracic outlet syndrome and compression of that subclavian vein by that first rib. So again, we can also do thrombolysis, surgical decompression, and endovascular interventions can also be used. So varicose vein treatments. So before we do any sort of treatment, we need a careful assessment of the greater saphenous vein. So if the GSV is competent and there's no reflux within the greater saphenous, we can do confined treatment of just to the varicosities. If the greater saphenous is incompetent, the vein should be ablated to reduce the reoccurrence of those varicose veins. The greater saphenous and its branches must be ligated to prevent the reoccurrence of these veins as well. Some basic varicose vein treatments. If the patient has primary varicose veins, they may just order compression stockings or support hoses to, again, counteract that increased venous pressure. They may also have order or perform a complete excision of the varicosities. Patients may undergo endovascular ablation of the varicosities. If it's secondary varicose veins, again, they may try support stockings. Patients may have to undergo surgical ligation and stripping of veins involved. Compression sclerotherapy for small varicosity branches, or a new or potential radio frequency ablation. Some of the older methods that you may encounter is something called vein stripping. So with this, surgeons make an incision in the groin that ties off the diseased vessel and then uses a stripper tool to pull the diseased vein out through a second incision. Patients might expect up to a 3-week recovery of that. So presentation of this, you might be imaging the common femoral. You see a little piece of the greater saphenous, and that's about it, and very little flow within that small segment of the GSV. So that's typically a patient who's had their veins stripped. They can also perform a vein closure. So this is less painful and less invasive. With this, the surgeon makes a small incision, inserts a thin catheter equipped with a high radio frequency transmitter or a laser attachment, which induces the diseased vessel to collapse on itself and seal off. Following the procedure, healthy veins develop and restore normal blood flow and improves systems and appearances. This procedure takes less than an hour. Patients who have had previous surgery for varicose veins may not be able to have a vein closure on that same leg. Another procedure is something called sclerotherapy. So this involves injecting a sclerosing agent into the vessel itself to shrink the vein. So something you might hear that would be, now they like to use saline injections as that sclerosing agent. Another procedure that's common is something called thermal venous ablation. So this is just a transverse view. Looks like it's probably either the greater saphenous or the small saphenous. This is definitely a superficial vein here. So we have a transverse view, and you can see the small echogenic center of that. That's the catheter with the laser attachment to it. With this procedure, that catheter will heat up, or the laser will heat up and actually cauterize or shrink that vessel itself. With this procedure, they actually also have to, under ultrasound guidance, inject a little buffer of fluid around the vessel itself to protect the surrounding tissue as well.
Before performing endovenous thermal ablation, the skin and surrounding tissues are numbed. The proceduralist makes a small cut in the skin, into which he or she inserts a very thin tube called a catheter. The catheter is guided into the vein to be treated using ultrasound imaging. The proceduralist applies radiofrequency or laser energy to the enlarged vein through the catheter's tip. As the catheter is pulled out, the heat causes the vein to collapse and eventually heal shut. The blood will then reroute through other veins.
So again, these are just some more videos that you guys can watch on your own time, just showing some of the radiofrequency vein closure procedures. This just is a chart showing the difference between vein stripping versus vein closure versus ligation. So you can see vein stripping and vein closure have pretty good results. Vein closure 2 years out still has 80% a delay. This is represents the delay in reappearance of the varicose veins. So 86% still don't have varicose veins 2 years out. So this is an example of a patient who may undergo sclerotherapy. So these are more spider veins, or these small varicose veins. So again, these offer good cosmetic results. They inject that sclerosing solution into the into the veins in order to shrink them and reduce the appearance of the varicosities. These are just some YouTube links that you guys can watch if you're interested in learning about some of these other treatments. So this just is a diagram showing kind of how you differentiate between varicose veins versus reticular veins and spider veins. So the varicose veins will have a diameter greater than 3 millimeters. These reticular veins have a diameter smaller than 3 millimeters. And spider veins, they're purplish and red, and are results of an AVF rather than a venous disorder. That finishes up week 1. So now getting into week 2. So venous duplex. When we're doing an assessment of our veins, there's really 3 main things that we're trying to accomplish with our venous duplex. That's to determine the presence or absence of thrombus, so clot, DVT, or if it's the superficial veins, superficial thrombosis or phlebitis. We're trying to determine the relative risk for thrombosis dislodging or traveling to the lungs. So a lot of that will play in part to the exact location and the size of the thrombus. So is it a proximal thrombus? Is it something, up in the common femoral, iliacs, femoral vein, or is it more distal thrombus? Is it down in the calf? So those proximal thrombuses, they have a higher propensity to dislodge and travel. And because they're a larger vessel, the clots tend to be much larger in size and pose a greater risk to the patients. And then the other thing that we're typically going to assess for, the other reason we do a venous duplex, is to assess the competence of the venous valves. So looking for reflux within the vessels. So those are 2 separate types of exams. And they will have separate indications. So you have to be careful, like when the order comes in just for a venous duplex, is it, is it to rule out DVT or is it a reflux study? So with duplex imaging, it's important to know the imaging characteristics of normal veins, the Doppler characteristics of normal veins. So what I mean by Doppler characteristics, is it a central vein like the subclavian or innominate? We know that those should be very pulsatile because of their proximity to the heart. Does it exhibit normal flow characteristics? Do we see respiratory variation? Do we see, continuous forward flow? So knowing what the normal characteristics of that particular vein segment is imperative to determine whether or not, there's a potential obstruction. When we're assessing the thrombosis, we want to know, is the clot, acute versus chronic? So I actually uploaded to D2L that little chart that I had. That showed acute versus chronic. So it's under week 2. So this is now on your chart for you guys to study. So again, acute versus chronic. With acute DVT, it's anechoic or hyperechoic. Chronic DVT, chronic thrombus appears brightly echogenic. Acute thrombus is more homogeneous, while the Chronic appears more heterogeneous, so there's more mixed echo textures. Acute thrombus could be poorly attached or floating. Chronic is usually well attached to those vessel walls. Smooth or acute thrombus typically has smooth borders to it, whereas chronic DVT can potentially have regular borders. Acute has a more spongy appearance to it, whereas chronic appears more rigid. In terms of the vessels themselves, acute thrombus, you have an increase in that vein diameter, so they become big, dilated. Chronic thrombus, we have contraction of the vessels, so they appear contracted, small. With chronic thrombus, we usually wind up with large collaterals that have developed over time, whereas with acute thrombus, the body hasn't had a chance to develop substantial collaterals, so we may often just see small little collaterals surrounding the native vessel. And again, we need to also be aware of our imaging protocols, so our upper and lower extremity imaging protocols and our instrumentation, what probes that we use. Thrombosis and thrombolysis. So thrombus, unfortunately, induces additional thrombus, and thrombus tends to propagate thrombus will propagate proximally. You'd be amazed, like some of the doctors that are out there. I remember I had one patient who was positive for DVT bilaterally in both, external iliac, common femoral, I think all the way down to to the popliteal. And the next day, the doctor ordered the same test again to rule out DVT because the patient was having new onset of calf pain, and they wanted to see if the calf veins were thrombosed. I had to explain to the doctor, you do realize, it's not going to get it doesn't matter if the calf veins are thrombosed. He's got all this clot up here. What's the point of doing this study, And he's like, well, I want to see if the calf veins are clogged now. I'm like, that really is inconsequential at this point. You worry about the clot going up, not going down, But needless to say, we still had to do the test. Doctors get what they want. But yeah, so just remember that clots are going to travel proximally. So we worry about propagation upwards. So patient that has popliteal DVT, we worry about extending now or propagating upwards into the femoral vein. Patient with femoral vein DVT, we worry about it propagation into the common femoral propagating up into external iliac. So we were looking for these clots to extend upwards. Thrombosis is also an inflammatory response at the vein wall. So we can potentially see thrombophlebitis or inflammation of that vein wall. This can cause cramping, focal pain, and tenderness. Plasminogen is an enzyme that chemically lyses thrombus. So the body releases this plasminogen to try and break down the thrombus itself. So that's why when a patient has a DVT, we only administer anticoagulant to prevent new ones from forming, because the body is doing the job itself to try and break down these clots. So it's the body's releasing this plasminogen, this enzyme that's chemically breaking down the clot itself. And it's just going to take time, for that clot to eventually resolve and break down and the body to take care of it on its own. It's a slow process. So these patients will typically go through serial ultrasounds to make sure that the body is breaking down the clots, that the anticoagulation is enough, to prevent new ones from forming, that's doing its job, and that's eventually resolving. Residual thrombus that does not lyse gets invaded by fibroblasts, and this creates a fibrous tissue or a plaque-like fibrous scar. So that's when we see that chronic DVT within the vessels. So that's that chronic DVT is a result of fibroblasts creating fibrous tissue within the vessel wall, and it creates almost like a fibrous scar within the vessel wall. So that's that echogenic linear echoes that we see with chronic DVT. So that's a result of residual thrombus not fully lysing and then being attacked by these fibroblasts. So it's nice when the DVT is able to, completely, disappear and completely break down. But, sometimes that's not always the case. So these are just some characteristics of a vein, of venous or veins. So characteristics of a vein that's free of thrombus. So it's fully compressible. We're able to coapt the vein, compress it down. We have nice normal Doppler signals. The vein fills completely with color. So color fill representation. Vessels fill completely with color. We can have non-occlusive thrombus. So again, we can have a portion of the vessel that's occluded. So that's why our color Doppler is a useful tool. We can put our color on. When we compress, the vein, doesn't compress down. We could still get a Doppler signal, but it appears more dampened. Though it could also appear normal as well, depending on the level of occlusion to that vessel. And we can visualize color flow getting around the area of thrombus. So we have an area where the thrombus is located that will not exhibit color flow. So we look for what's called color filling defects. So this is an important tool that you guys can have in your toolbox, when you're doing a DVT study and the patient's in extreme pain, they're fighting you, no, I can't do this test, no, they're refusing, no, don't, stop pushing, I can't do this, at least try and give the doctor color pictures showing complete vessel filling. So that's one way you can kind of prove to the doctor, hey, I imaged this vein in this segment, I went down the leg, I didn't see any sort of filling defects. I wasn't able to do the compression maneuver, because the patient wasn't unable to tolerate that portion of the exam. But at least you gave them some information, you give them the Doppler waveforms, you give them color flow images showing the vessel, completely filling with color. So at least they get a little bit of diagnostic information rather than just, giving them, all right, fine, you're refusing the test, we'll stop right here and then and there, So oftentimes those patients will tell me, all right, I'm not going to push anymore. I'm just going to lightly take some pictures. So this is characteristics now for an obstructive thrombus. So those veins, when they become completely occlusive or obstructed, again, they become quite dilated and enlarged. They're totally non-compressible. There's absent Doppler signals and absent color flow. So again, it's just a little breakdown between chronic versus acute thrombus. And so the main things we look for, acute dilated veins, hypoechoic to anechoic, spongy in texture, poorly attached. Chronic is brightly echogenic, well attached, and the veins are typically contracted. So imaging characteristics of normal veins. So we know that they're smooth, thin walled. We may see echogenic structures within them. Those are going to be our valves. They're compressible, so the walls do not coapt when the lumen contains thrombus. So we're able to compress them down. They're able to coapt completely in a normal setting. We do this in transverse. So this is the primary criteria for duplex imaging for DVT. When we're talking about normal vein size, the major veins of the arm and thigh are larger in diameter than the corresponding arteries. So typically the arteries are going to be larger than the veins. Vein size may increase by back pressure from congestive heart failure, proximal venous obstruction, or venous reflux. So just keep that in mind. Veins may appear small if the patient is dehydrated or severely vasoconstricted. So it's just our respiratory changes again. So inspiration, again, increases upper extremity flow, decreases lower extremity flow. Get the opposite with expiration. And then our Valsalva maneuver reduces both upper and lower extremity venous flow. It's just a sonographic image showing a nice echo-free lumen with the thin wall and complete vessel filling with a color Doppler. So there may be conditions, again, where we exhibit sluggish flow within the veins themselves. So this is our Raylos flow. In echo, we call this smoke. So this could be due to several different factors. Could be due to a more proximal obstruction, something blocking that blood flow within the vessel themselves. So a more proximal DVT. Could be due to a proximal compression of that vessel, say from a mass or a tumor, or a large lymph node, or in cases of May-Thurner syndrome, could be that right iliac artery compressing that left iliac vein. This can also be very common in women who are pregnant. So you have a woman who's, 20, 30 weeks gestation, getting towards the end of her pregnancy, that baby becomes pretty big. It's running out of room, so it may be compressing now one of the iliacs, maybe compressing the IVC. So those patients will could potentially wind up with sluggish flow within the veins. So one of our CVS students, Morgan, she went out on maternity leave, and she's actually gonna be joining your cohort next year. But when we were scanning her veins at this point in the semester, she started developing some sluggish flow within her vessels, and we blamed it on their baby. And that's one of the reasons too why they instruct pregnant women to lie on their left side as opposed to their right side, because their IVC is on the patient's right. So lying on your right side will shift that baby towards the IVC. It could potentially compress the IVC. Some normal venous structure. So here we could see the vein and the vein apparatus. So we see the valve annulus and the sinus of that valve. So remember that these sinuses are nice areas where thrombus could potentially form. The valve sinuses appears to have thrombus behind the leaflet in A. The same valve, after the vein has been compressed, actually milked out that stagnant flow. So with this image here, the technologist was imaging. They applied a little bit of pressure on that valve and compressed it in the area of the valve. And that what appeared to be thrombus actually got milked out. So it was just some stagnant blood that was within that valve sinus. So again, with veins, we have compressibility. So that's a good way to differentiate between your artery and your vein when you're imaging. Compression is done in our transverse view. So this is just an image showing the patient's right common femoral with and without compression. So this is what we're gonna, what we began here in the lab with our split screens. And this is what we're gonna do with pretty much all of our venous studies. So here it shows a transverse view in 2D, what looks to be appear as a thrombus within that vessel wall. When we performed compression, the vein actually compressed all the way down. So we know that that actually wasn't thrombus. It was more likely probably just stagnant blood. Could potentially just be artifact. Maybe our gain was a little too high, so you can hit it with a little bit of TGC. So you really have to rely on that compression maneuver, to ultimately determine if there's thrombus within that vessel or not. So this is now an image for common femoral vein showing thrombosis within the vessel itself now. So when we put our color box on, we see no flow. So that's going to be your first sign. You put this box on, you don't visualize any flow. You perform your compression maneuver. The vein is non-compressible. So this is just now showing another vessel. Here's our common femoral. So we can tell that this is the left common femoral. We're in transverse. This is running inward medial towards the patient's thigh or towards the groin. Arteries are lateral. So with and without compression. So this vessel is non-compressible. So this is an example of an acute thrombus. You can see it appears, anechoic, hyperechoic. You just have to be careful that you do not to perform what's called a false positive. So in this case, the vein did not fully compress, which could suggest the presence of thrombus. In this case, the lack of compressibility of the vein is due to the patient bearing down in response to a painful compression, and thus not allowing the vein to collapse completely. So in these cases, you may want to, change your technique, maybe change the patient's position to compress near any bone, compress harder if need be. I like to have the patients take a nice deep breath out. So this is an image now for a longitudinal femoral vein. So showing nice phasic respiratory variation. So you have nice phasicity of that waveform. Good augmentation. So this is our distal augmentation. So this is a nice, normal, healthy waveform within a vessel. This is showing nice compressibility of the femoral vein. So we have our superficial femoral artery, femoral vein, and then the vessel completely coapting. So here we could see lack of compressibility for several vessels. So we have artery and vein. We have a vein over here. So this arrow indicates the vein, the one of the four veins that was actually compressible. So this is going to be at our bifurcation between SFA and DFA, deep femoral artery, and the associated veins with that. So this one partially compressed. We could see some echogenic within it. So there's probably a little more, this clot is more chronic in nature, probably. This one's partially compressible as well. This one as well, it's got more echogenic intraluminal echoes. So this is a good example showing vein size. So our posterior tibial artery and the two posterior tibial veins. So you can see these vessels are quite dilated. We see absence of color flow within them. So this is indicating an occlusive thrombus within those vessels itself. Appears hypoechoic, particularly to the surrounding tissue. So this is an example of an acute DVT within the posterior tibial veins. So we have normal respiratory changes, normal respiration versus Valsalva. So having the patient Valsalva will actually increase vessel diameter, should increase vessel diameter. In the presence of thrombus, however, there will be no change in vessel size with the Valsalva maneuver. So if we have a thrombosed vessel, patient Valsalvas there'll be no respiratory changes to that vessel itself. So our Doppler characteristics of normal veins. So typically we should have spontaneous flow. So what does that mean? We should have a continuous forward flow that follows the patient's respiration breathing. So Spontaneous flow is normal when present. Flow is often not spontaneous in small veins, such as the calf, hand, or foot. So as we work our way further away from the lungs themselves, we lose that spontaneity. That's why we really rely more on that calf muscle pump and our skeletal muscle contractions for circulation of venous circulation within those smaller vessels. We look for phasic flow. So it's called respirophasic. So the flow should follow our breathing patterns. So we should see velocity flow changes in response to our inspiration and expiration. And we may also be able to exhibit cardiac pulsations, so particularly in our proximal vessels. So we see that cardiac pulsation in our subclavian and nominate. We can potentially see it in iliacs. When phasic pattern is absent, this is referred to as continuous flow. So when we lose that phasicity, that, breathing in, we get those little waves, we get the momentary pauses in the flow. When we lose that, the flow is then referred to as continuous flow. So a continuous flow pattern can indicate the presence of thrombosis or more proximal obstruction, something that's taking away that influence of the lungs in our phasicity. Just remember that a phasic pattern may sometimes persist even if a thrombus is present, because that thrombus could potentially be partially occlusive and not blocking that entire vessel lumen. With Valsalva, we should have an abrupt cessation of blood flow and then a dilatation of the vessels. This helps to document the patency of the venous system from the point of Doppler to the thorax. An abnormal response occurs occurs only with substantial venous obstruction. So what that means is if we don't get that Valsalva response, it's a result of having an occlusive thrombus or an occlusive or a substantial venous obstruction. Some of the other characteristics are going to be augmentation. So this is a manual compression distal to the site of duplex imaging and results in an increase in venous flow. The augmentation can confirm patency between the site where you're imaging to the site where you're doing your augmentation or your compression. So that's why I like to do, a distal augmentation down by the calf. That's the proper way to do it when you're performing the augmentation maneuver. And that gives a good indication, if you're Dopplering up by the common femoral and you augment down at the calf and you're getting a good strong augmentation, you can at least rule out the presence of an occlusive thrombus completely blocking, the vein between where you're imaging at the common femoral and where you're augmenting down by at the calf. And then the other thing we're going to look for too is unidirectional flow. So we want to make sure that the flow is going in a forward direction, back up towards the heart, and not the presence of reflux. So you can actually appreciate, your bidirectional flow within the veins if you have your color box on, and you see the vein flashing from blue to red, back to blue again. That would indicate the presence of bidirectional flow. So we want unidirectional flow. So this is just a chart showing spontaneous and phasic flow. So we have forward flow, one direction above the baseline. It's continuous flow, follows our inspiration and our expiration. So we have a nice phasic flow pattern. When we lose that phasicity, this is what's referred to again as continuous flow. So this would be a continuous forward flow pattern. So again, it's above the baseline, so it's in one direction. but this is now referred to as a continuous flow. So a couple things to keep in mind, vasodilation from infection of inflammatory processes may result in a continuous flow, as well as vasoconstriction from trauma, pain, anxiety, or the need of the body to conserve heat may have markedly decreased venous flow signals. So a good habit to get into when we're trying to, determine if we have phasic flow is to optimize your waveform. So, decrease your scale to make these waveforms larger so you can get a better appreciation of the phasicity of that waveform. So in this case, I may be able to move this baseline up a little notch, so we have more room underneath the baseline, and then lower my PRF a little bit, make it even a little bit bigger. So I know Christian is big on showing phasicity. That's one of the main things that they're going to look for in their venous duplex examinations. So optimize your waveforms to show phasicity. So this is two images. The left lower extremity iliac vein demonstrates decreasing flow velocity in inspiration due to an increase in intra-abdominal pressure. On expiration, the velocities increase, so we get that phasicity. Over here, this is a right lower external iliac, demonstrates mild cardiac pulsatility. This can be indicative of changes in the right heart during right heart pressures during normal cardiac cycle. So it is possible to see some pulsatility, particularly in these more proximal veins in the leg. So this is an example here of what continuous flow would look like. So we see, typically decreased velocities and just loss of that, real loss of that phasicity, that respiratory variation. So this indicates a proximal venous obstruction. So again, that obstruction could be within the vessel itself, so a thrombus within that vessel itself, or it could be a result of extrinsic compression on that vessel seen proximally. This is an example showing pulsatile venous flow. So if we see pulsatile venous flow and we're pretty far away from the heart itself, that could be an indication that the patient has right heart failure or congestive heart failure. So seeing a very pulsatile flow, so you see these sharp peaks. Sometimes this can be even more exaggerated. So you get above and below the baseline, it becomes biphasic. So this can be an indication that a patient has congestive heart failure. And if they have congestive heart failure, typically these veins will also be dilated as well. So Valsalva response. So in normal venous flow with our Valsalva response, we should have a cessation or a pausing of venous flow. And then upon release of that Valsalva, we should actually see an augmentation. So we should get a momentary period of increased forward flow and then return back to our normal phasicity. So there's just some pictures showing Valsalva response. So we get cessation of flow. And then here we have normal flow, Valsalva, and then with release of Valsalva, we should see an augmentation, a slight augmentation of flow. So this is just a diagram showing what our waveform should look like when we perform distal augmentation. So we should have just our normal phasic respiratory variations. And then we augment, we squeeze, give a light squeeze to the calf. And we should see a spike or a surge of blood going back up to the heart. So that's a positive augmentation. That's what we want to see. So that's good. And a patient that has a distal clot, So a clot below the level of where we're imaging that's occlusive. When we do our augmentation and we get no response, that's a result of that clot, preventing the blood flow from going back up. So again, so we can use augmentation to assess for distal thrombus from where we're imaging. So lack of augmentation is a result of a clot below the level of where you're imaging. So an occlusive thrombus below the level of where you're imaging. This is just another image showing calf compression. So a normal common femoral venous flow, and then the patient, the stenographer augmented. So we see a nice surge of blood going back up to the heart, and then a return back to our respiratory variations. And just another picture showing normal augmentation. This is the right popliteal now. So just keep in mind that this is less useful when you're assessing the popliteal vein, because we have 3 paired veins, that are feeding into the popliteal at this level. So, it isn't necessarily a good indication of the lack of presence of a thrombus. So when we're talking about unidirectional flow, so we can actually, exhibit and quantify the amount of reflux within the vessel by looking for flow above the baseline or in the opposite direction of what our normal respiratory variation has the blood flow doing. So in this case, if we have a patient Valsalva and we get a period of blood flow that changes direction, that appears above the baseline, from our normal respiratory variation, this is an example of what reflux would look like on our Doppler waveform. So we can determine the severity. We're going to get into this a little bit later. The severity of this reflux based on how many seconds it is. So these large markers indicate 1 second of time. So in this case, we have 1 second, 2 seconds, 3 seconds, 4. So basically 5 seconds. Might have gone even longer if they didn't have the patient release at this point, but that would be considered severe reflux. Basically anything over 1 second within the deep system is considered significant. This chart just shows normal sonographic features of normal veins. This was, again, that scoring chart for testing the probability of a patient potentially having a DVT. I'll be perfectly honest, this really isn't utilized in the clinical setting. Okay, so acute versus chronic thrombus. So acute thrombus, hypoechoic, anechoic, poorly attached, has that spongy texture, veins are dilated and are more likely to embolize. So this is example. So we weren't really able to appreciate the thrombus too well with our 2D, put our color flow on. So now we can visualize, the areas where the thrombus is located and some flow actually getting around that thrombus itself. Just again, so some more images for acute thrombus. So in this one, this would be a free floating thrombus. So if we were watching this in real time, this would probably be flapping around, moving around inside the vessel. And we could appreciate flow around the area. So again, we're looking for that filling defect. Some more images showing some mobile thrombus within the common femoral vein. Again, you put your color flow on, you can visualize and appreciate the borders of that thrombus with the filling defects. So other thing to just be cognizant of when you're doing this is make sure that your gains aren't set too high, that you're bleeding over the thrombus and actually masking it or hiding it. At the same time, you want to make sure your gains aren't too low, that you're not picking up slow flow. So they could potentially be slow flow. That's why in this case, this technologist used a power Doppler to appreciate, the flow around the thrombus. So this is just a longitudinal view of the common femoral vein containing a fresh thrombus. So again, the fresher it is, the more anechoic it's going to appear, or the more hypoechoic and anechoic. You can see the presence of faint white lines are the actual reflection from the thrombin net that has recently captured the blood components and to form into thrombus. So again, we see nice, large distended vessels, absent flow, non-compressibility. So this just kind of talks again, acute versus chronic. So this term isn't commonly used as subacute phase. So this is as the body's trying to, heal and get rid of and lyse and break up that thrombus. It eventually starts becoming more echogenic. So we demonstrate increased echogenicity. We have decreased size in the thrombus and in the vein size. We could see adherence of the thrombus, particularly along the vessel walls. We could see a return of flow. So a vein may not fully return to normal. We may see thickened walls and reduced vein caliber. So when you're writing up your report, you might use terms like recently formed thrombus rather than acute. So this is just showing superficial femoral vein. This would be a collateral that's developed or duplicated SFE, where they have one channel that's open and patent, and then the more posterior channel that shows maybe just a small area that's become recanalized. This picture just shows an acutely thrombosed superficial femoral vein. So you can see a large superficial femoral vein here in the presence of a perforator connecting into that SFV. So this is showing a vessel that's attempting to recanalize, so open back up. So the body is lysing and breaking down that thrombus, and we're starting to get a return back of flow within that vessel itself. This is 1 month post thrombosis. So with chronic thrombus, again, this is a sequela venous thrombosis. Sometimes it's also referred to as chronic venous scarring. So this is typically seen in months to years after initial thrombotic event. These chronic thrombi appear brightly echogenic, hyperechoic. They're well attached. Again, they appear rigid in echo texture, sometimes forming what looks like a scar or web-like scar. Veins that have chronic DVT are typically contracted, and there's typically the presence of large collaterals. Because that vein is not contracted, the body still needs to get that blood flow up back to the heart. So patients that have chronic DVT will typically have large collateral vessels within the area. Patients with chronic DVT, the vessel walls are typically thickened. We can see the presence of those fibrous cords. They often have valve abnormalities, so those valves typically get damaged as a result of the deep vein thrombosis. And that damage of the valves will lead itself to the patient developing reflux and insufficiency. So unfortunately, reflux and insufficiency is a common byproduct of patients who've had deep vein thrombosis. Within these chronically scarred vessels, we may lack spontaneous flow, we may lack phasicity, we may observe the presence of reflux. They may also have abnormal response to Valsalva or augmentation maneuvers. So here, when we look at this chronic DVT or this DVT in this vessel, when we turn in sagittal, we start looking for these elongated linear echogenic structures. So that's one of the first signs that, that this patient is developing chronic thrombi. So in this patient, the vessel hasn't recanalized yet. Here we see a large collateral adjacent to that vessel. So here's a good example again of the chronic DVT. So in this vessel, we have recanalization. So we have a return of some flow. We can see areas that appear very echogenic. When we turn in sagittal, or when in sagittal, we can see adhered to the wall. We see echogenic wall thickening, or that brightly echogenic scar. It almost appears calcified. So these are examples of a chronic thrombi or chronic changes. So here we could see also that echogenic calcified thrombus. We actually can see some posterior shadowing in this case. Again, some more examples of chronic thrombi. We see these linear echogenic strands. So they almost appear cord-like. So this is that residual chronic thrombus. Again, we also could see thickened venous walls. So there's a wide range of what chronic thrombi could potentially look like within the vessels. So in this case, we actually aren't able to detect any discernible flow within the vessel itself. Here we can just see kind of a linear echogenic line coming across the vessel. Here we can see more substantial echogenic linear echoes within the vessel itself with some recanalization of the flow. So typically these chronic vessels will have small residual lumens. The flow will sometimes take a disturbed pattern, or we can have almost complete recanalization. So if I was to put color flow on this one, this would probably almost all fill up with color, but we just see this linear echogenic structure. And that's when getting a good patient history, is important. If you see something like this within the vessel, you can ask them, have you ever had a clot in your leg before? Do you remember which leg it was in? They may not remember or know that it had reached, this particular level or segment. But yeah, they're like, oh yeah, I had a clot in this leg before, it was 20 years ago, I had a DVT or something like that, So these are just some more pictures for some chronic DVT showing that the fibrous scar, the stranding, the linear echogenic stranding. So in transverse, it may look like just a line, transversing across the vessel itself. We can visualize, again, thickened walls. So we see diffuse wall thickening. May present as a central linear echogenic scar, may be adhered to the wall itself. So again, the surfaces, they also look irregular. So we have irregular surfaces when the vessel is starting to recanalize. So some more chronic DVT, we could see the thickened echogenic walls. We get some shadowing from calcification of that vessel wall. So this picture here now, this is an acute thrombus. So this shows in a partially occlusive acute thrombus. And transverse, you can see flow going around that central thrombus. When we turn in sagittal, again, we can appreciate the filling defect. And the area without the flow is our thrombus. Collateralization. So collaterals may be located adjacent to the thrombosed vein or more distally. They're typically smaller and often tortuous or braided. Collateral flows are more continuous in nature, and they're abnormally located. They can often be difficult to compress as well. Collaterals usually cannot be followed for any significant length. So this is just a venogram of the right showing an extensive network of venous collaterals where the femoral vein is occluded. So when collaterals appear large and are seen, it is a reliable indicator of a chronic problem. So just remember, if it's acute DVT, the body hasn't really had a chance yet to form those collateral pathways. So you may only see small collaterals, where if we visualize large collaterals, it can indicate a chronic problem. So again, just another chart showing difference between acute and chronic DVTs. Another comparing acute and chronic. Again, easily seen because they're echogenic, compressibility, both incomplete compressibility. Differences in the echogenicity. With Valsalva, they may become larger. Again, collaterals not seen, typically with acute, often seen with chronic. It's just a partially occlusive DVT seen within the femoral vein. So to me, this looks like it's more chronic in nature. I'm seeing these irregular borders to the thrombus. I'm getting some linear echogenic stranding to it. So with thrombus, it's important to show the extent to which the vessels are thrombosed. Of most importance is that maximum proximal extension. So we really want to know how far up that thrombus goes. So if you're coming down the leg, you're starting with your common femoral and you're compressing down and you reach a level where you see thrombus, try and go back and show an image exactly where, that proximal extension is, how far high up it goes. So the doctors, can appreciate, how far up the thigh. So you may be somewhere in between like mid thigh and proximal thigh. You want to give the doctors a real good indication just how far up it goes. So that roadmap that you provide the doctor will help guide anticoagulation therapy as well. So when we're talking about instrumentation, we'll typically use a curve probe or a low frequency probe for imaging the iliac veins and IVC. Potentially also for the subclavian if it's a large patient. When we're looking at the veins of the legs and the arms, we're typically going to use our higher frequency linear probes or our 5 to 7.5 megahertz transducer. We commonly use even higher frequency probes, so this could be a higher frequency linear transducer or even our hockey stick probe for looking at the superficial veins. So we want to have a higher dynamic range, so more shades of gray to improve our grayscale resolution. We use pulsed and gated Doppler device, so it's sensitive to detect slow flow velocities. We use color duplex to identify small veins and confirm flow. So this is your typical upper extremity venous duplex protocol. So it's going to include both superficial and deep veins, particularly with the upper extremities, because again, the upper extremities are going to be the ones that the nurses are going to target when they're doing their IVs, blood drawns. So those are the ones that are going to receive most of the trauma. So we're also going to assess the deep veins as well with patient preparation. You're going to obtain patient history. So you're going to want to know, have you had any IVs or lines in, because they may not have them in currently. So they may have worried that that line became infected, or they're worried about, that the patient may have developed thrombophlebitis, and they'll preemptively remove that line. That's the issue. So that you may not even know that they've had a line. So always ask, have you had any lines in? Have you had any bloods drawn? Also with patient history, you want to know, particularly with women, have they ever had breast cancer on one side, and the side that has this swelling? Have they ever had any lymph nodes removed from that particular side? Any surgical procedures? What are you feeling? What are your signs? What are your symptoms? Tell me where the pain is. Where does it hurt? You'll do your physical exam, assessing, like looking for swelling, looking for any sort of palpable cord, try and feel the area that really hurts, that's swollen. See if you can feel a palpable cord. Is it warm to the touch? You want the room warm. Try and have them relax. For upper extremities, typically have the patient supine or recumbent or sitting. You can have the head raised for the arm veins imaging. So for jugular and subclavian, try and avoid the bed being completely flat, which can cause have the bed more flat to avoid collapsing of that vein. I apologize. So if they're sitting upright, or if they're raised, the head's raised a little bit, sometimes that can cause the jugular or subclavian veins to collapse. If you're able to lower the head lower than the actual feet, that would actually really open up the subclavian and jugular veins. In terms of the protocol, we're going to check compressibility, assess for spontaneous flow. Augmentation of Valsalva responses may also be necessary. We begin with internal jugular vein. Compress again the length of the jugular vein. Transition to the subclavian vein. If possible, try and image the innominate. See if you can see the innominate dipping down. Try and image the subclavian vein in its entirety. So begin medial or the proximal segment with the junction with the brachiocephalic, continuing out towards the shoulder. Particularly if the patient has a central line or a PICC line, you want to try and visualize that PICC line in its entirety to see if there's any thrombus developing along that PICC line. We can potentially have the patients try and augment using the sniff technique. So we look for sniff augmentation. So that's a good indication, potential thrombus. We then transition to imaging the axillary vein. Axillary vein then transitions into the brachial veins. And we compress again. We do compression of the internal jugular. We do compression of the axillary. So we don't typically do compression of the subclavian. So that's where our 2D and color Doppler imaging, as well as our pulse wave imaging, become critical. We continue again with compression for axillary and brachials. We can compress the entire length of the brachials all the way up to the elbow. And then we can compress the radial ulnar veins, continuing down the forearm. So we go from antecubital fossa down to the wrist, performing our compression maneuvers. Cephalic vein runs from the junction with the subclavian all the way down towards the wrist along the lateral aspect of the upper and forearms. So again, you want to compress along the course of the cephalic vein, particularly cephalic and basilic. Those are your two superficial veins. So those are the ones that will typically have IVs in them, or they'll have the blood drawn from them. So you want to make sure you're assessing those veins in their entirety, particularly around the areas where those IV insertions were. On here, you may also want to assess that median antecubital vein, because that's a nice site where, you know, oftentimes an IV is going to go. So remember, the basilic vein forms a junction with the brachial vein to form the axillary. Within our upper extremity duplex exam, we're going to rule out or identify venous thrombosis in the upper extremities. We can differentiate again between acute and chronic. We can be used to evaluate non-occlusive thrombus. We can use it to distinguish between extrinsic compression versus intrinsic obstruction. Our duplex exam can also be used to perform something called a venous mapping or vein mapping. So we're going to learn a little bit more about that. And can reveal recanalized channels or evidence of collateralization. Some limitations for our upper extremity exam. Evaluation of subclavian can be difficult, and innominate and brachiocephalic veins may not be seen due to bony structures. This kind of circles back on some of the previous slides. Again, imaging our internal jugular vein, seen more superficial than the artery or anterior to the artery. Just two images for a patient with a jugular vein. So we see a nice patent jugular vein. And then one that appears thrombosed. So you could see it becomes very large, dilated. You can appreciate the intraluminal echoes. So this is just subclavian vein scanning now. So again, the technologist went along the jugular vein, angled inferior, trying to visualize that brachiocephalic, and then just kind of rotated the probe out to open up the subclavian vein to visualize the proximal segment of that subclavian vein. This is just showing jugular vein would be coming down, brachiocephalic, and then subclavian. So again, cephalic vein connects into the subclavian, usually around that mid-level, mid to proximal segment of the subclavian. So you can utilize two approaches when trying to image subclavian. You can attempt a supraclavicular approach above the clavicle, or an infraclavicular approach just below it. So you can see a long axis and a short axis images here of subclavian vein. So important to note with subclavian Doppler signals, we want to see some degree of pulsatility within that vessel. So that's pretty important when we're imaging subclavian vein with our upper extremity duplex exam, because we're going to be comparing it to the contralateral side, to the opposite side, and looking for any disparity or differences between the pulsatility between the two sides. So it's important too to make sure that when you're comparing the two, that your scales are set to the same size or same scale when you're imaging the contralateral side, because you may have adjusted during the course of your exam. So make sure you go back to what your initial setting was for the side that you were imaging. So we should be able to visualize respiratory variations and those cardiac pulsations. And we should be able to also demonstrate sniff augmentation as well. So just remember, there's going to be segments of the subclavian vein that we cannot adequately visualize or assess due to shadowing. So this is the clavicle itself and the vessel running posterior to that clavicle. So moving the probe from the lateral chest wall towards the axilla, keeping the beam pointed posteriorly. We can now visualize the axillary vessels. So here we could see the axillary artery, axillary vein, basilic vein. So these are just some transverse views of presentations for the vessels. So when we're imaging axillary artery and vein, we should typically have one axillary, one and one. So one artery, one vein. As we move further down the arm into the upper arm, we should be able to visualize the brachials paired and a single basilic vein. Further down the arm, this is what the brachial veins will look like. Again, they're paired, so two veins and an artery. Getting down into the forearm, we have the brachial veins then split into the radial and ulnar. So we can see split screen of our axillary artery and vein. Here's the same image without the color on. Just our axillary vein, our transverse probe position, longitudinal color. So these are just some sonographic images now in the upper arm for the brachial and basilic veins. So again, we're going to look for our brachial artery and try and visualize our paired brachial veins on either side of that brachial artery or around that brachial artery. So you could potentially have a vein up here, a vein over here, the other vein down here. So they don't necessarily have to be exactly on either opposite sides of that artery itself. So we try and locate the brachial artery, try and find the brachial veins adjacent to that brachial artery. And then the basilic vein is going to be by itself separate. Basilic vein is going to appear more medial. So we're going to go more inward in that arm. Basilic veins are typically going to be a little more lateral. So if we see, brachial veins are more lateral, become more medial, and we can visualize the basilic. So basilic's more medial, brachials are a little more lateral. So here we can see again, we're able to locate that brachial artery. We can see a brachial vein, two brachial veins associated with that artery, and then the basilic vein by itself off to the side. It's another transverse image. So we find our artery, the vein, and then the basilic vein off medial off to the side by itself with no associated artery. So when we do our compression, everything should compress down except for that artery. This should be an easy one. Brachial artery, your two brachial veins, and basilic vein. It's just some images now for the brachial veins again. So these are going to be paired, two veins, one artery. So this would be with and without compression. So the brachial veins can be visualized all the way down at the antecubital fossa. So the brachial veins don't actually split until you get into that proximal forearm. So down at the antecubital fossa, you can actually visualize the median antecubital vein. So this is again the brachial veins down near the antecubital fossa. So the radial ulnar bifurcation is slightly distal or further down to the antecubital fossa. So again, it's going to be in that proximal forearm. The ulnar vessels dive while the radial vessels stay at the same depth. This is the median antecubital vein up here. Again, look for your arteries as your landmarks. So here you have your radial vessels, your ulnar vessels. So these are, as you're working your way down the forearm, these are going to dive deeper and run more medial. These are going to stay more superficial and start coursing more lateral. So for forearm scanning, the probe is going to be on the lateral forearm for the radials. On the right, the probe is on the medial forearm for the ulnar vessels. So this is showing the radial vessels. So again, look for your artery, and then try and find the two adjacent veins. And then cephalic vein running by itself superficial. So again, you just want to make sure everything compresses down. So with and without compression. This is just a picture just showing some more ultrasound images of the various vessels within the upper extremity. So this is our jugular vein and transverse. Here would be on the left side, left innominate, proximal left subclavian, and the internal jugular vein coming down to meet the two. This would be a transverse view of our subclavian vein. Axillary and vein is going to be anterior to the artery. Getting down into the upper arm, you should try again, visualize, find your brachial artery, find the two paired veins, and then the basilic vein more medial off by itself. Now just here we have just the brachial veins, and then down in the forearm, we have radial and ulnar. So with the cephalic vein probe position, now we follow the cephalic vein over the deltoid muscle down the arm to the elbow. Just remember to use a light touch with this because it's very superficial. So we can visualize an image of the cephalic vein at its junction with the subclavian. So we can start at the top of the bicep. Follow it down to the mid-arm. Cephalic veins vary in size. This one is very small. So this one over here just measured 1.6 millimeters. Again, so the basilic vein takes a more medial track. So this is kind of a good schematic. So this is more inside, the more medial aspect of that arm. Brachial is more lateral. So if we're coming down, we have to shift our probe inward a little bit more along the inside of that arm to image the basilic. More along the outside of the arm or more lateral is going to be the brachials. So we can have some anatomic variations of that medial antecubital vein. So we said that this median antecubital vein or mid antecubital vein is a connection between the cephalic and the basilic veins. So cephalic, runs down the outside of the upper arm. The antecubital fossa and continues down the forearm. And we have a connection between the two in that median antecubital vein. So basilic vein running down along the medial aspect of the arm and then continuing down the medial aspect of the forearm. So this just shows some different presentations. So A being the most common configuration. All right. So interpretation for these vessels. Normal upper extremity venous findings. Veins are going to be widely patent. The walls readily coapt if compressed with the transducer. Some veins are going to be covered by bones and other structures that may not be completely compressible or visible. If valves are seen, they are competent and thin. Doppler and color flow patterns are spontaneous with normal phasic changes. We will exhibit pulsatility of venous signals in the subclavian and innominate, so that's normal. Again, so abnormal findings would be thrombus that appears as echogenic or hypoechoic material within the lumen. Doppler flow patterns that may present as continuous or of elevated velocity. Color flow patterns that may be absent or partially occlusive. Color indicates recanalized channels through thrombus, could potentially indicate recanalized channels through thrombus as well. So one thing to be cognizant of when you're imaging upper extremities is the presence of nerves that run along with these vessels as well. So particularly in the upper arm, we could see a nerve bundle in the area of the brachial veins and basilic veins with a circular incompressible structure. So in the longitudinal view of this circular structure, we see the unchanging size proximally and distally with striations throughout the structure. So that's one way you can kind of confirm that this is a nerve and not a vessel. So you can actually see kind of, I'm sorry, over here, I apologize. So over here. In lab, we'll see if we could see anyone's nerve bundle. Another way to differentiate, between vessel and nerve. If I'm in transverse and I'm tracking this up and down, it's just going to kind of disappear on itself. It's not going to join back in with any other vessels. So if it's a vessel, the vessels will all connect, particularly in veins. If you're traveling superior, that's going to connect back into a larger vessel, into a larger vein. So think of it as tributaries of a river. So you're trying to follow the river back to the ocean. So if it doesn't connect to anything, it kind of just disappears. It's most likely just a nerve. And again, just look for these, open it up. It's going to say uniform in length. You're going to have these linear striations, these echogenic striations. So that was upper extremity. So just kind of going into now lower extremity. So patient preparation and position. Again, we want to obtain our patient history. So that's going to include signs, symptoms, any surgical history. Have they had any sort of procedures in their legs, any sort of venous ablations, removal of veins for cardiac bypass? Have they harvested any veins? Have they done any endovascular procedures? We want, again, the room warm. We'll do our physical exam, assessing the legs. We want to have adequate venous distension with dependent position. So we want the feet a little bit lower than the head. So we can have the patient in a reverse Trendelenburg position. We're going to rotate our hip externally and have the knee flex slightly. So I call it that frog-legged position. In terms of technique, again, you may have to use your curve probe if the patient is very obese or if they have a very large limb, very muscular, gentleman who's very big. You may not be able to get the penetration with our higher frequency probe. And then conversely, if you're imaging some of the superficial veins, you may need to switch to a higher frequency transducer. Again, we're going to demonstrate compressibility, spontaneous and phasic flow, augmentation and Valsalva responses when necessary. Going to typically begin with either external iliac or common femoral, depending on the lab that you work at. They may have you begin with external iliac. So it's very easy to image the distal external iliac. Basically, you get your common femoral image, where the greater saphenous coming in, and you just slide up a little bit, tilt up a little bit to get just that distal portion of the external iliac. And you can try and compress and turn in sagittal. Again, so just come above that level of that inguinal ligament. So we're going to image common femoral, we're going to image that saphenofemoral junction. We're going to image femoral vein, so also called the superficial femoral vein in its entirety, making sure we're compressing from proximal all the way down to distal. We'll image the proximal segment of that deep femoral vein. We'll image popliteal. So in this case, you may have the patient turn prone or in a lateral decubitus to get posterior to the knee. We're going to image the calf veins. So most clinical settings, you'll image posterior tibial and peroneal. Almost never will you image the anterior tibial veins unless, indicated. If that's exactly where the patient is having pain or swelling, then, potentially you might image those vessels, but typically no. Most sites would just be the posterior tibial and peroneal. So this just goes over the capabilities of our duplex again. To rule out or identify thrombus, differentiate between acute and chronic thrombus, acute and chronic changes to the vessels, distinguish between, again, extrinsic compression versus intrinsic obstruction. We can use it for vein mapping, document non-vascular soft tissue masses, and search for the presence of collateral channels. Some limitations, the iliac veins may be difficult to image, as well as the infrapopliteal veins, so the calf veins. So they may be very small in diameter and caliber. Compression may be limited due to patient size or muscle contraction or muscle mass, and also patient's ability to tolerate compression. Just the image showing our branches for the lower extremities. So position. So I like to, raise the head up a little bit, lower the feet down a little bit, so that'll aid in some distension of the veins. It's a nice habit to get into. That sometimes I'll put a towel underneath the knee, give a little support to the knee, particularly patients or anyone who's got knee pain or knee issues. Make it a little more comfortable for them. So we can image the iliac veins. We were doing that in the lab, particularly the DMS ladies and Godwell. And we were coming from a more lateral approach to image that bifurcation of the IVC into the common iliacs. You can also image the bifurcation of that common iliac potentially into the external and internal. If you're gonna take an approach from the groin, we'll only really be imaging that distal external iliac vein. So again, imaging of these more proximal vessels is not commonly done in our venous duplex exam for the lower extremities. This is a good image showing an acute external iliac DVT. So the echogenic line you can actually see is going to be our inguinal ligament. So we're actually above that level of that inguinal ligament. Turn in sagittal. The iliac vein will come from the top corner and run inferior. So the vessel will come across your screen like that. So again, this shows no intraluminal filling. This would be an acute DVT with hypoechoic echoes, spongy texture, dilated vessel. So this is an acute DVT. So we see in this case asymmetric respiratory variation. So patient's right appears more continuous. So we have continuous forward flow. We don't have that respiratory variation that we see over here on the left side. So that should automatically raise red flags to you when you're imaging this patient. So if they've ordered a unilateral exam and you're just imaging one leg and you get to the other side when you're imaging, doing that contralateral image for the external iliac or common femoral, and you see this should automatically send up red flags. And a good sonographer will then try and interrogate more proximal, maybe try and image the IVC or that bifurcation. So if I get this, I can also kind of deduce that it isn't an issue with the IVC because I have respiratory variation on the left side. So it's probably somewhere along that proximal external iliac that I'm not getting, or I'm losing that respiratory variation, or potentially in that common iliac. So it could potentially be on the right side, external iliac proximal, common iliac, but IVC would most likely be okay, or potentially be partially occlusive in the IVC as well. We don't know, but this would definitely indicate, a more proximal occlusion somewhere going on that you should potentially investigate if possible. So in this case, this patient, it was it was caused by a large uterine fibroid or a large pedunculated leiomyoma that was compressing the upper external iliac vein and the common iliac vein. So this picture shows IVC thrombus. So this is going to be our sagittal view for our IVC coursing underneath, posterior to the liver. So you could see what looks like an isoechoic or hypoechoic structure within the vessel itself. turning in transverse, you can appear, hey, this really is real. It's lying there within the vessel. It's kind of at the level here of the renal veins, it looks like. So far as the color flow on this, I might see partially occlusive flow. So color flowing around that area. Showing our pro positions for imaging. So again, when imaging femoral vein, you just want to make sure you're compressing as you're working your way down the leg. We have common femoral again. I don't really like this picture, to be honest. Like if this is just before the bifurcation or if that's actually at the junction itself, but eventually you'll get, as you work more distal down the leg, you'll get separation of that common femoral into superficial and deep femoral. We typically only image that deep femoral again at that proximal segment, and we'll continue to follow this superficial femoral vein down the thigh. And typically that femoral vein starts running deeper as you run more distal. So this just shows the proximal thigh vessels. So if we come more superior, we'll have just femoral, common femoral vein, common femoral artery. Come down a little bit more, we'll get that junction of the greater saphenous, the saphenofemoral junction. Come down a little bit more, we still have the common femoral vein. It hasn't bifurcated yet, but we do have bifurcation of the arteries already at this level. Coming down a little bit more, then the vein has now split or bifurcated into our superficial and deep. And as you continue down the leg, you get more separation between the profunda or the deep and the superficial femoral artery and vein. So if we had to ascertain if it was right or left, I look at which direction that greater saphenous is pointing towards the groin to determine if it's right or left. So this way the GSV is pointing inward in the left leg. So this is going to be the patient's left leg because the GSV is pointing inward here, or it's pointing medial. Or GSV is always going to point medial. So if it was the right leg, common femoral would be on this side and GSV would be pointing inward towards the groin for the right leg. Oh, it's just common femoral vein with and without compression. So again, we're at the common femoral level, arteries are going to be lateral, veins are going to be medial. So for in transverse, this is going to be the right leg. GSV would be branching off that way if it were in this image. So this just shows normal augmentation response. And it's going to be one of our Mickey Mouse signs with our greater saphenous or saphenofemoral junction. So again, this is going to be right leg now. Arteries are going to be lateral, veins medial. So look what's, just think of your where your notch is on your transducer. So again, so the primary diagnosis for thrombosis is going to be that lack of compression or coaptation of the vessel walls. These are just some pictures showing some free floating thrombus. So free floating thrombus in two different patients. So just remember that compression maneuver can also pose an increased risk for embolization. and should be avoided when thrombus is incompletely adherent to the vessel walls. So if you see something flapping around like that, try and avoid, doing compression. So document it, put your color on. You don't, so, and try and avoid compression, of that. In addition to compression, trying to avoid performing augmentation as well. So this is common femoral artery and common femoral vein with and without compression. So normal or abnormal. This is definitely abnormal. The vein compresses down only slightly with thrombus within the vessel itself. So again, this is common femoral vein and artery now. So veins are going to be more medial. So this is going to be the left leg. We're in transverse. This is our notch. Notch is pointing, going to be medial in this case. So we can tell that this is the left leg. So we also have to be careful of, again, that slow flow or that Raylos flow, that Raylos formation that can mimic the presence of DVT. So here I see, that smoke or that swirling of flow. It looks like interluminal echoes. Put color on. Oh gosh, I don't see any flow going on here. But when I compress, it compresses down. So I'm like, all right, what's going on? So when you release, sometimes you'll get flow now back within that vessel, or you could try lowering your scale, your PRF, to try and make it more sensitive for cell flow. Maybe put on color Doppler, or potentially do a distal augmentation. So if I augment, I'll get that, that surge or that spike of flow going back up to the heart. I can fill the vessel doing some distal augmentation. So I could prove that, yes, it does fill, that was just artifact or that Raylos flow or smoke. So again, this could potentially be caused by either a proximal compression of that vessel higher up or by proximal obstruction higher up. So imaging the saphenofemoral junction. So we're going to try and image that greater saphenous connecting into that common femoral. Remember that this is a common site for reflux. So the GSV is going to empty into the common femoral just below the level of the groin crease. When we want to see complete compression of both the greater saphenous and the common femoral. This is just a transverse image showing greater saphenous connecting in. So again, we want to show right common femoral, left common femoral, and with and without compression. We want to make sure that everything compresses down. Complete compression. So in the course of doing our exam, we could potentially encounter thrombosis of the greater saphenous vein. When we do encounter thrombosis in that proximal segment of the GSV, it's important for us to measure the distance from that thrombus to the junction. So this should be a measurement that is done if we see thrombosis of that proximal greater saphenous vein. Typically, a clinician will worry if the thrombus is within a centimeter of that junction. Here it says 0.5 to 1 centimeters. So sometimes they'll order anticoagulation if it's close to that junction because they worry about this extending in and eventually entering into the common femoral itself. So that's something that you might potentially observe. So you might see a clot within the common femoral vein, and as you're tracking it back, you see that it's actually just extension of a GSV thrombus into that common femoral. So it's a small segment of that common femoral. So that clot is actually extension from the GSV. And then you might also see that the femoral vein and the deep femoral vein are completely patent and normal, and it's just that extension of that thrombus into the common femoral. So here's an example of that. So greater saphenous with some extension of that thrombus into the common femoral. So this would be considered a DVT because there is clot actually now within a deep vessel itself. And this patient should be treated with anticoagulation. So partially occlusive thrombus, so common femoral vein near the SFJ demonstrates an enlarged vein containing intramural echoes. Common femoral vein is partially patent with color flow demonstrated. So we get some flow coming through that GSV into the common femoral. So there is some partial flow within it. We can, in sagittal, we can demonstrate occlusive thrombus formation in the femoral and deep femoral veins, extending into that common femoral. So just be careful. So for color bleeding pitfalls, so if our color gains are set too high, we can actually mask a thrombus. So this color bleeding partially obscures a partially occlusive thrombus. So lowering your color gains down to appropriate level reveals that thrombus. We can visualize it here when we turn in our transverse view. So that's that same thrombus along that posterior vessel wall. And also don't mistake a lymph node for a potential thrombosed vessel. So you should all be comfortable with the appearance and presence of what a lymph node looks like, their typical location. So we're typically going to see these in the groin and the proximal thigh. Just remember, they're going to be they'll be more superficial to the vessels themselves. They should have a similar orientation in both sagittal and transverse. There will be some vascularity to these, so you can, if you put color flow on, you should be able to pick up some degree of vascularity, depending on if the patient, has any sort of infectious process going on in that leg, like cellulitis or an abscess or some sort of infection in the leg. These may be very hyperemic and have increased vascularity to them. And if you were to Doppler it, you should be able to pick up arterial signals in it as well. So it's going to be different from a thrombosed vein. So this just shows. I think that's a good spot to leave off. Vein. Yeah, so I'm going to stop here. I apologize if a lot of these slides are kind of repeat, but I want you guys to just really be comfortable with, being able to visualize the veins, know what vein you're looking at, what segment you're at. Get comfortable with being able to recognize right versus left on an ultrasound image. These are the types of things that might appear on your registry, particularly ID in vessels and vascular. Know your differences, between acute and chronic DVTs. I think you guys are pretty good. I'm going to keep uploading and just dumping more pictures for you guys to go through. The more slides you go through, more pictures you go through, recognizing DVT, you'll never miss one ever again. So again, when you're doing your exams, the most important thing is just being careful with your compressions, making sure the veins compress all the way down and that you're slowly compressing as you go, compress every segment as you're working your way down the legs, don't just jump, boom, boom, boom. I've seen it as a student. I've seen it as a tech. You get lazy. Some sonographers get lazy. They'll just do one picture here, one picture here, one picture here, and just kind of boom, 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 rather than compressing the entire length of that vessel, going slow. We're not in any speed contests with this, especially young sonographers starting out. A good hospital always preach quality over quantity. They rather you, be thorough and careful with your exam than miss a DVT just because you're trying to rush through an exam. So good scan practices. All right, so in lab, we're just going to continue with our upper extremity scanning. Finish that up. And I'll see you guys in a little bit.
Thank you.
You're welcome.
Okay, Dan,
Sure. Yeah.
so the second group is starting at 1.